have a few housekeeping items. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the HMA and the Johnny Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find the evaluations by following the link in the chat at any time, or look at our website or our email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers are expected to disclose to the audience any real or apparent conflicts of interest that may have a direct bearing on the subject matter of the program. Dr. Miyamoto has disclosed that she has no relationships with commercial supporters that could be perceived as a conflict of interest. It's my great pleasure to welcome Dr. Miyamoto. Dr. Robin Miyamoto is a clinical psychologist who earned her PsyD from Argosy University and completed her clinical training at Tripler Army Medical Center with a specialty in health psychology and behavioral medicine. For the last 20 years, she has been active in promoting training opportunities in primary care psychology, particularly in rural and underserved communities within the state of Hawaii. Her areas of interest include diabetes, kidney disease, and cancer. She is a past president of the Hawaii Psychological Association. She's an assistant professor and director of clinical services in the Department of Native Hawaiian Health at the Johnny Burns School of Medicine, University of Hawaii. Please join me in welcoming Dr. Miyamoto.
Good afternoon, everyone. Thank you for having me. I am happy to be presenting this afternoon on the determinants of health and resilience in the Native Hawaiian community. I'm going to try to save some time for questions at the end, but I will ask for a little bit of participation at different points, so feel free to unmute your microphone and shout things out. Okay, so as we get started today, we're going to be talking about the social determinants of health and health inequities. We're going to talk about those specifically as they pertain to the Native Hawaiian population. We're going to talk about those impacts that were felt during the COVID-19 pandemic. And then we're going to talk about some positive activities that are going on in Native Hawaiian communities. I have my own disclaimer. I may say things today that challenge beliefs and could be taken as offensive.
Sorry, Robin, we don't see your slides yet.
Oh, I'm so sorry. I thought I shared them.
Thank you. Yeah, sorry.
Give me 1 minute. How about now?
We can see them, but they're not in presentation mode.
Okay. Okay.
Perfect.
So,
Thank
sorry.
you.
So for the disclaimer, I may say things today that challenge beliefs and could be taken as offensive to your status quo. These are my opinions and not the opinions of the Departments of Geriatrics or Native Hawaiian Health. I raise these issues not to raise defense, but to shine a light on the inequities that prevent good health for all in an attempt to improve the systems we work and live in. I also acknowledge my marginalized status as well as my privilege when I say that I am a mixed race, Asian, Caucasian, cisgendered, divorced, elderly female who went to private schools until college and is the child of healthcare professionals. Apparently ageism starts at 40, so I have to add this to my disclaimer of being elderly, much to my dismay. And I wanted to start with a quote today that means a lot to me by Austin Channing Brown. I believe firmly that to practice love is to disrupt the status quo, which is masquerading as peace. So before we get started today, I know we have a number of JABSOM graduates. I at least saw a Jester there in the group, but I want you to remember back to the Reno unit and PBL, and there was Bobby Kealoha that you folks met with a couple times. And at the end of the case, he asked you, how come we Hawaiians have so many problems with our kidneys, doc? I want you to think back to what your answer was or what you might tell one of your current patients if they were to ask this question. We're going to come back to it closer to the end of the session today. So the social determinants of health is probably a concept that people are pretty familiar with by now. The social determinants of health are the economic, social, cultural, and environmental conditions that influence individual and group differences in health status. And so this little cartoon is, the kids are so close together just with that little space between them. And the little girl saying, how come you're rich and I'm poor? And the little boy saying, my mom and dad have highly paid jobs working on that very problem. And so that's what we're going to be talking about today, but we're going to dive a little bit deeper into things. So this is the part where I want you to throw into the chat or unmute your microphones and tell me a little bit about how our environment impacts our ability to care for our health. And if you recognize this background, this is, of course, MEB, our own job sum right in the heart of Kaka'ako, where we have some big challenges in terms of houselessness and access to care for many of our populations. But go ahead and throw it in the chat or unmute your microphone. Anyone want to share how our environment impacts our ability to care for health? Okay. Well,
Hello,
so
I'll share.
Okay, thanks.
It impacts, the environment impacts our health with either through access or lack of access to many important things, such as healthy food options, ability to engage in physical activity in a safe way in our communities, access to healthcare, and our environments are often influenced by our socioeconomic levels and so forth.
Well, thank you. Cave's clearly my plant this morning, but I appreciate going through the list. And you can see there's even more things here, and then we'll be talking about some of them today. But in terms of the environments that we live in, they affect all of the choices that we're able to make and not make with regards to our health care. And we're going to be talking more about that. So who are most affected by social and health inequities? And it's the populations that, as we've talked about, are marginalized and don't oftentimes have a voice in the public policy discussion. So Native peoples and Blacks, women, children, elderly, the poor and marginalized, those who are politically underrepresented, the undereducated, and those living in impoverished neighborhoods. So before COVID, in 2008, there was an HBO documentary entitled Unnatural Causes. And this really brought the concept of the social determinants of health to the general public. They reviewed 10 arguments in an attempt to explain the health disparities we were seeing across our country at that time. They're listed here talking about the fact that health is more than healthcare. It's not just what happens in the room when you're with your doctor. It's about the jobs we do, the money we're paid, and that health is tied to the distribution of resources. So again, going back to where the money is. And that racism imposes an added health burden. And we're going to talk the most about that today. The choices we make are shaped by the choices we have. And that's definitely the case when we're looking at this picture. It's very difficult to be able to make healthy food choices when you're limited by access to them, the ability to afford them, or living in a food desert where there's not places to buy healthy foods. High demand and low control equals chronic stress, that chronic stress can be deadly, and that inequality, both economic and political, is bad for our health. And the US has by far the most inequality in the industrialized world in terms of the haves and the have-nots. And as a result, we have the worst health. Social policy is health policy. And as we start to change those social policies, health expectancy grows. And that health inequities are not natural. This is not something that should be happening that has to do with genetics. This is something that we've caused with our environment and with our policies, and that we all pay the price for poor health. So that was 2008. And then of course, we know a little more than 2 years ago, our world kind of exploded, and it was the day that everything changed, and it really brought to light these health inequities when we think about who was affected by COVID. And it also brought about the Black Lives Matter movement into focus, Asian hate. It really threw everything upside down. And as a result, now we're really seeing that racism is the foundational determinant of health. So that it's the racism, not race, which is a social construct, that's the primary driver of those social determinants of health. And this model by Parodies really demonstrates that racism and racist policies is the root that we can trace all the determinants of health back to. And that's where we need to start when we're talking about ways to improve this system. So just so that we're all on the same page, let's give a definition of structural racism. And we talked about the fact that social determinants of health were described as a product of the circumstances, but we know now that those practices and policies were created by structural racism. And so structural racism is defined as the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. We're not going to talk a lot about this today, but I think it's just important to note that whites are affected by structural racism as well. And it's something that we need to educate folks on so that there's more buy-in when it comes to changing policies. But white Americans who are believing in racist ideas that people of color will just use and abuse, take advantage of social entitlement programs like Medicare for All or Social Security funding or paid leave, things that other countries have. But what happens is they reject these policies because they don't want to let anybody skate by on these systems. And what happens is that they lose their own social security or social safety net when they fall. And that's what we saw during COVID. So because these programs were not in place, there wasn't a safety net for a large majority of the population. And because those were the folks that had the power, that's when suddenly we saw an increase in unemployment benefits, that those benefits went up $600 a week because the people with power suddenly started to realize that nobody could possibly live off of that amount of money. And so those are the types of experiences that may actually lead to us being able to change the system. I want to bring it back to Hawaii and talk about racism in Hawaii. So in 2019, the New York Times ran an article entitled, "Want to be less racist? Move to Hawaii." It promoted the myth of the melting pot, that because we are all mixed, that there's no racism here. The more passive Hawaiian values such as aloha or lokahi, that idea of everybody being able to pull together, remind me of another great quote by Austin Channing Brown. "When you believe niceness disproves the presence of racism, it's easy to start believing bigotry is rare and that the label racist should be applied only to mean-spirited, intentional acts of discrimination." And so I'm highlighting here this statue in Thomas Square, which I'm sure most of you drive by on a pretty regular basis. But it's an example of how racism and racist policies are rampant here, and we're going to talk more about that. But this is one that really affected both funding, but more importantly, it affected health. And so here you see the statue of Kamehameha III. It cost $250,000. It was not commissioned from a Native Hawaiian artist. It wasn't commissioned from an Indigenous artist or even a Black artist. It was commissioned from a white artist in the southern area of the continent. So that money didn't stay here or support the local art community. The park improvements that they spent at Thomas Square amounted to $2.8 million. And this went to pay for irrigation, new grass, walkways, and a flagpole. And this was in a time right before COVID where we were very, very strapped for money, and that just got worse with COVID. But we contrast that to another community in Waimanalo that at the same time had a park that had fallen into disrepair, but construction was delayed while the Thomas Square project went through. And this was the gym that for many of the children in Waimanalo, this was their safe haven after school. It's where they had their after school programs. It's where they had their summer fun programs. It's where they had their sports practices. And because of the lack of funding, the gym was closed down and the kids were not able to participate in those activities. We saw increases in drug use, we saw poor educational outcomes, and increased rates of obesity because they weren't able to be playing in their park. And so racism does matter to health when its underlying resentments and anxiety shape larger politics and policies and then affect public health. We see this again with this ZICTA data that Ranjani Starr and her colleagues put together out of the Department of Health. And so people are always quoting that Hawaii is the healthiest state in the country with the longest life expectancy. And it's true that our entire state has a life expectancy of just over 82 years. But when you look at it by ZICTAs, which is relatively equivalent to zip codes, you can see that the areas with the highest Native Hawaiian population, so out on the Waianae Coast, as well as the area in Waimanalo, there's almost a 10-year difference in life expectancy. And you're talking about the difference between the area of Ainahaina, which had the highest life expectancy at 87 years. The distance between Ainahaina and Waimanalo is less than 10 miles, but that translates to a 10-year difference in life expectancy. And that's because of the racist policies and where the monies are going to in terms of bringing programs that support healthy activities and health in general across our state. So for the myth of the melting pot, I just want to go over one of my patients that was particularly a frustrating case and a great example of racism and how it affects healthcare. So my patient was a 40-year-old Native Hawaiian female. She had a history of major depressive disorder, post-traumatic stress disorder, and also really bad fibromyalgia. She lives in Waianae. She lives in a multi-generational household. Right now, she's living on welfare and food stamps. She was denied Social Security disability for her fibromyalgia and her mental health problems. We had her go to her PCP to get medication for the fibromyalgia, and she was denied Lyrica because it was a Schedule 5, although that's the lowest possible addiction potential. They were not willing to prescribe the Lyrica for her and insisted that she see rheumatology. She waited over 4 months for an appointment with rheumatology. And then when she did finally see the rheumatologist, she was told to reduce her stress level and meditate. She wasn't given medications. She was told that she needed to lose weight and reduce her stress level, which I'm not sure if folks know when you get welfare in the state of Hawaii, how much money that means, but it's $300 a month. So it's really hard to reduce your stress level when you're living on so little money, really relying on other people to be able to survive. And the only way that she was able to get the Lyrica medication and have some relief from her pain was she actually switched her primary care provider to a Native Hawaiian female physician who was willing to help her and prescribe that medication. And so we see these cases on a regular basis of how judgments are made and patients don't get the care that they need. So to go back a little bit, the parallels between the Black experience and the Native Hawaiian experience are numerous and reflect a long history of colonization. In the first nationwide compilation of racial crime data, there was a book that was put out by Frederick Hoffman, and this was in the late 1800s. And he was using the higher arrest and incarceration rates for Black Americans as an argument to say that by their very nature and behavior, they were dangerous and violent people. And he used those disparities to argue that they were causing their own extinction and that as a race, they would eventually die out. He cataloged higher Black mortality rates and also higher rates of syphilis, tuberculosis, and other infectious diseases compared to white Americans. But as we go through this history, you can identify a lot of similarities that we've heard when we talk about the Native Hawaiian population. And so to highlight that, in 1895, there were over 300 men, women, and children. This little picture here is of a 14-year-old boy who were arrested because they were loyal to the Queen. And so many of those that were arrested were not criminals. They were in fact professionals. They were lawyers, physicians, businessmen. And these slides and this history was gathered by a historian named Ron Williams, and he came across a book labeled Political Prisoners. But when he showed these pictures, there were people in the audience who recognized family members out of these 300 folks and realized that these were the first people in their family who had gone to prison. That was the start of the high rates of incarceration among Native Hawaiians. And they can trace it back not to criminality, but to loyalty to the Queen, and that these were highly educated Hawaiians that were arrested and held to the point that they lost the majority of their assets. So in one case, there was Judge William Henry Daniels on the island of Maui. He was a large landowner. He had 10 children and owned Maui Food and Taro Company and a large portion of Kaho'olawe. But when he refused to take the oath against the new government, he spent 4 months in prison. When he got out, they had foreclosed on all his mortgages and he ended up losing all of his businesses. He was blackballed and he couldn't find a job. And 18 months after he was released from prison, he took his own life. So these parallels between the Black experience and the Native Hawaiian experience really help to set the stage for us understanding how racism is really shaping our policies, but also our health. If we look at the history of Native Hawaiians before the missionaries arrived, they were a very, very healthy population with very low rates of obesity. There was no evidence of diabetes in the population. And these were documented by the explorers that were coming to Hawaii before the arrival of the missionaries. So this is not a genetic predisposition that exists. The health was here. It was the changes that happened that caused the decline in health. And this is too much to go over in our time together, but you will have access to this timeline that was put together by Dr. Koholokula that goes over the pre-contact and post-contact of the missionaries. And the most important thing to note is that the Native population was estimated to be between 500 and 800,000. And by 1900 was down to 30 to 50,000. And that was because of the infectious diseases that were brought by the missionaries. And so we can see that the arrival of the missionaries, the arrival of Christianity and colonization had a huge impact on the health of Native Hawaiians, that it is not a genetic predisposition. And then in the more recent years, as we've seen the Hawaiian Renaissance, the reemergence of the Hawaiian language, of cultural activities, are we seeing an increase in the state's population as it starts to, or the population of Native Hawaiians across the country as it starts to approach the pre-contact numbers. So when we're talking about health inequities, it's really easy to say, oh, it's bad choices that are affecting people's health. But when we take a look at it, the factors that affect health that are related to the health behaviors really only account for 30% of health inequities. And the other 70% is coming down to those social determinants of health that we were talking about, the social economic factors, the physical environment, and then access and quality of care. So when we are in the office with patients trying to get them to take their medication or eat healthier foods, we're really only impacting 30% of their overall health. When we look at what has happened to the health of Native Hawaiians since that missionary contact, unfortunately, Native Hawaiians are leading in terms of inequities with higher rates of obesity, hypertension, diabetes, mental health issues, and substance abuse issues. I think the only ethnicity that has higher rates of hypertension, unfortunately, are Japanese. But in all other areas, it's the Native Hawaiians that really are having the brunt of those health inequities because of the racist policies and those social determinants of health. As we saw in the Zicta slide, this means that there is a lower life expectancy by 10 years, and also that Native Hawaiians contract disease younger, 10 years younger than their white counterparts. And this we've seen in dementia, we've seen it in arthritis, cardiovascular disease. And so those are the inequities that we're trying to target, but we can't do it by just targeting those health behaviors alone. The cultural determinants of health, when we're talking about Native Hawaiians, is extremely important because it's not just the environment, it's the historical or cultural trauma that Native Hawaiians were subject to. So the history of cultural marginalization, that colonization, land being stolen, language being banned so that there was no way of expressing themselves in their native language, and then losing a lot of those native speakers. At the same time, we really want to focus on the preservation and resurgence of cultural traditions, of language, of cultural dance, of cultural practices, and also those sacred places that mean so much to Native Hawaiians and that Westerners continue to take over in the name of tourism or science. This access to lands is an important part of repairing the structural racism that exists. In the importance of helping to build that strong Indigenous identity with some of the cultural programs that I'll talk about at the end, and just really encouraging that cultural participation. But that's hard when people are working a couple jobs and trying to make ends meet. We really need to have easy access to these programs, and people need to have a livable wage that allows them to be able to participate in these programs. So again, this is a slide that was put together by Dr. Koholokula listing out the social and cultural determinants of health, and so that you can see the historical determinants, which goes back to the racist policies, the social, political, and social economic determinants, again, racist policies. And then the last three areas are really seeing the impact from those policies and how they affect the biological factors that we might see when a patient is in our office, as well as those mental health issues. So when we go back to this original slide from the beginning and we're talking about the social determinants of health, we realize that similar to other Indigenous populations, and this is from First Nations in Canada, is that we can't just look at the social determinants of health, that there's so much more that needs to go on in terms of cultural well-being and eliminating structural racism and reconnecting people to their history and their culture as we start to look at what wellness means instead of just repairing those health disparities. Now I'm going to go back to Bobby Kealoha and have you reflect back on what you told him when you were in MD3, or what you may tell your patients now. So when he asked, how come we Hawaiians have so many problems with kidneys? It's not that there's a genetic predisposition. We know that race and ethnicity play a role in understanding someone's social determinants of health, but in the majority of circumstances, it's the racism that is impacting their ability to make the choices that they need in order to promote good health. There's absolutely no race-based genetic predisposition to diabetes or renal disease. And as a healthcare provider, if you tell your patients that they have kidney disease because it's genetic, it's tied to their Native Hawaiian ethnicity, that really disempowers them from being able to make any positive change. Focusing on the social policies that have gotten the health to this point helps them to realize that they have some power to be able to make different changes, and maybe even empowers them more to challenge themselves to overcome the racist policies that have resulted in the poor health. But if you tell them that it's because they're Native Hawaiian, that takes away any power that they have to be able to make a difference in their own healthcare. And that's the mistake that many physicians make when they look at the data. So when we're talking about the resilience and cultural revitalization of the Native Hawaiian population, it's so important to look at the resurgence of language that with our Hawaiian language immersion programs, such as Punana Leo, that we've seen a sharp increase in native speakers. We've seen people returning back to traditional diets that are not simple carbohydrate based. And then also looking at different activities that get people outside and reconnected to their culture, such as voyaging, canoeing, hula, and then helping people to reconnect to that culture, to feel proud about their culture instead of focusing on so many of the disparities. So this resilience and revitalization is what we can credit the sharp increase in the population with, and really is going to be so critical when we think about the health of the population that is increasing. So when we look at this slide and we see the increase just from 2000 and what's projected out to 2050, the population, looking at both Hawaii and the continent, is set to be close to 1 million. But we need to be able to make these changes in social and health policy in order to impact the health of this population, so that it's a healthy close to 1 million people, and not a healthy, and not a million people with significant chronic disease. We need to be able to promote the programs that are going to reduce those health disparities. So the challenge then becomes, how do we dismantle structural racism? And I think we are at a pivotal point right now in terms of DEI initiatives and what does that actually mean. And we can have lots of trainings on it, and we can make sure that everybody has checked the box and done those trainings. But unless we really start to dismantle the racist policies that underlie that, we're not going to be able to make a difference in things. And so this is a model that was put forth by the Aspen Institute of the 4 steps that you really need to focus on in dismantling structural racism. And I'm going to take us through the steps and what's being done in the Hawaiian community to do that. The first one is that racial equity must be a center goal of the work. So when we think about what some folks have called vaccine hesitancy, that again tends to put blame on the individual, that they are hesitant in getting the vaccine, that they're not getting vaccinated, while not looking at the barriers to why that reduced vaccine uptake exists. And this is a good model for that racial equity. So the idea of a difference in vaccine uptake, we need to be able to look at things from a more systemic approach. So in terms of the barriers, a lot has been written about having trusted voices as part of the marketing campaign, because there's so much mistrust of medicine and science. And this mistrust is coming from a reasonable place. There's a long history of unethical practices and research on minority populations. There is a long history of racism in their individual healthcare. And so they don't have the relationship with healthcare providers that someone else that has always had very positive experiences may have. And so overcoming those barriers, it was, we need to get people out in front. We need to get recognizable, trusted voices to talk about the importance of vaccination. And this was a really useful practice, but it fell short of true partnership. And so true partnership really requires partnering with those trusted organizations who already have ties to the historically marginalized communities. So Native Hawaiian and Pacific Islander organizations who've been there before COVID, who've developed these relationships and can have a very hands-on approach and get their, roll up their sleeves and get into the work, because those are the folks that people are going to trust when it comes to, should I or shouldn't I get a vaccination? That's where we look at the role of community health workers, and they were so important in terms of that high touch versus high tech. They really demonstrated the importance of person-to-person communication. And in communities with the highest risk of infection, which was early on the Pacific Islander community, the local community health workers were really the ones that were able to get more people tested, connecting them with the care that they needed. And eventually they were the folks that were able to increase vaccination rates, to get into the communities. And they understand that they don't have all the knowledge that they're paraprofessionals, but they do know that they have ties to the community that physician providers don't. And that relationship was really the key to increasing vaccination rates. They also were crucial in terms of language and translation skills and going into these communities. In this high touch, high tech situation, Again, we need structures, policies, and practices that are focused on ensuring Black and Brown communities in clinical settings receive doses of vaccines in a timely manner. So, sorry, to go back to the equity in vaccine distribution, we really need to look at mobile units and pop-up clinics. We need to look at partnering with local community organizations or individuals in order to advance the health equity. And so when we're talking about equity in distribution, when it comes to the vaccines, Dr. Giselle Corby-Smith, who is a Black cardiologist from North Carolina, really felt like vaccine hesitancy in that term and the concept was really a scapegoat for structural racism. And so when we're looking at equality, which is the top line of the slide where everybody gets the exact same bike regardless of their size or need, we don't hit the populations that we need to in order to fix those health disparities. It's only when we look at equity, which is everybody gets the bike they need for their size or situation, that we're able to get vaccine rates up. So when you give everyone equal access, as we did with online scheduling with vaccines, it exacerbated the inequities in vaccine uptake. The disparities got wider and wider when we saw unequal access to broadband and internet, computers, time to visit online vaccine distribution sites. And so we saw huge lines. People were not able to get the vaccines in a timely manner. If any of you tried to get the free COVID tests from our federal government, you weren't able to get them if you lived in an apartment the first time it rolled out, because the system wasn't built for anyone in an apartment to get a test. You only could order a test if you lived in a single family home, which again brings back that equity versus equality conversation. And because minorities are so disproportionately disadvantaged in the institutions of our society, attending to their needs in these action items with lower priority or as an afterthought is not enough to develop long-lasting solutions. We really need to look at the core in forming mission statements and programmatic goals around these populations if we're going to see improvement in any of these areas. And so we saw with COVID, obviously, that there was extreme disparities in terms of how it was hitting different ethnic groups. And this is the number 2 piece of things, which is where we need to counter popular assumptions that work to reproduce the status quo. So when we're thinking about how it was affecting minority groups, we really started to think that it was because of the bad choices that Brown and Black people were making when it came to COVID. And this is the COVID Racial Data Tracker. That is a national tool that was started at the beginning of COVID. They stopped collecting data at this point, but you can see here that Pacific Islanders were particularly hard hit with 41% of the cases in Hawaii and 32% of the deaths, despite being only 10% of the population. And so it's very easy to make the assumption that Black and Brown people were not taking the virus seriously, they weren't social distancing. But then when we got a lot of data back, survey data that was coming out there, they were actually taking it more seriously than their white counterparts. And at that point, then people start to say, oh, it's their pre-existing conditions. They're obese, they have diabetes, they have lung conditions. But no, it all came down to racist policies. And we need to be able to change those policies if we're going to be able to address these health disparities. This is Hawaii specific data here, where you can see this is the pre-vaccination period. And for Pacific Islanders, they were accounting for 25% of the cases with a much lower representation in the population. And this is because they were our frontline workers. They were at the grocery stores. They were at the fast food places that were still open. They were living in multi-generational households where you couldn't isolate if somebody in the house got COVID. And so this is where we're seeing those racist policies play out. And then once you have vaccines available, you can see the difference here in terms, the rates are more on par. But then when we switch over to Native Hawaiians for the post-vaccine status, that's where we see that vaccine uptake is not as high, not because of them being more at risk for contracting COVID, but because of the exposure to racist policies that they've developed mistrust of the healthcare system, and we didn't see the vaccine uptake that we were hoping for. So literally during COVID, people were dying of racism, and I'm sure that folks are familiar with this case that happened at Indiana University. Dr. Susan Moore was a physician who was hospitalized for COVID, and her symptoms were not taken as valid. She was sent home just with pain medication, and ended up coming back in with more complicated COVID symptoms, and she ended up dying of COVID. The hospital claimed that when they reviewed their records, there was no difference in the care she received compared to other patients. But when they conducted an external review of the hospital records, they identified that racial bias as well as a lack of empathy and compassion were present in her care, and ultimately increased the factors that led to her death. And this is what we're seeing in communities across the country, and why we need to be able to make these changes. So during COVID, there was a lot of these health disparities that we've talked about today, but a lot of solutions that came out of those. And we saw community organizations really step up and start to make the changes that we needed, even without the change necessarily in policy. One of those community groups is Kulanona Po'e Hawaii, which is the Papakolea Homestead community. And they were able to step up during COVID. They were able to secure extra funding. They were putting together monthly food boxes for everyone in their community. They were distributing kupuna meals through Meals on Wheels. They had COVID vaccines that were done by a Native Hawaiian physician in collaboration with the Kaiser Health Systems. They had community events to engage family. You can see this is one of my favorite pictures here. This was their mobile mele, where they had musicians driving through the community playing music. And then they were also distributing COVID test kits and masks and hand sanitizer. So this is really an example of that community capacity building that is that last, that fourth prong of how we dismantle structural racism. Looking at other community programs that are out there, the Board and Stone program is one that folks may have heard about, which was established by Uncle Earl Kava'a. And this is a cultural program in which families come in and make their own board to pound kalo with. They make their own poi pounder. And it's really a chance for families to connect to each other and to connect to their culture. And over 9,000 folks have already completed this program. You can see from one of the participant quotes here that it really improved the family relationship in terms of the dad really being more involved with his family and including them in some of his cultural activities that he used to just do on his own. But again, this is a example of those community capacity building programs that we need to see more of. From an academic standpoint and research standpoint, Ola Hoi Kahula is a program out of our Department of Native Hawaiian Health, an NIH-funded study looking at hula as the key component for reducing blood pressure, and the cultural education as well as the medical education that went along with participants that were in the program. And they saw reductions in blood pressure and overall cardiovascular risk reduction, as well as improvements in the patients or the participants' connection to each other, their cultural identity. But this is an example of culturally based intervention programs that could be covered by insurance, that could be available to folks outside of an NIH-funded research study, but should be something that is available within the community. And then to look at a clinical example of culturally based programs, there's the Native Hawaiian Navigator program at the Queen's Healthcare System that was started by the Queen's Department of Native Hawaiian Health. connecting Native Hawaiian patients to community health navigators to walk them through the system, to explain what was happening, to make them feel a connection to somebody within the hospital, to walk them through this process. The program was actually so successful that it was transitioned into a program that is now available to all patients who enter the doors of Queens, but the attention really needs to go to Native Hawaiian programs, because as we've seen throughout the discussion today, the improving health of Native Hawaiians is going to improve health of everyone. This is good health for all, but Native Hawaiians as the indigenous population deserve the attention to their culture to be able to fix the cultural and historical trauma that exists as a result of the colonization. I do have a link, and I can send these separately in an email to Kathy for some recommended videos that explain cultural and social determinants of health, as well as some films that I think are really helpful when we're thinking about how we address health disparities. Okay, that was a lot of me talking. I would love for people to ask questions, put it in the chat, unmute their mics.
Robin, thank you so much for a really enlightening presentation. Very interesting to hear about some of these historical events and even recent events. Very, very interesting. For those of you who have any questions, could you please type them into the chat box, or you could unmute yourself and ask the question as well. And John has just put the link for the evaluation. Don't forget, you need to do the evaluation form to get CME. It's in the chat box as well. Anybody have any questions or comments for Robin? Robin, I have a comment, just that, we work with the Papakolea Homestead folks quite a bit for geriatric training through our geriatric workforce grant through HRSA, and they did a heroic job during COVID. In fact, we had to kind of postpone some of our trainings because their entire focus went towards COVID, rightly so. And they did so much for their community in terms of just little things, like even just giving food and making sure that the older population who couldn't get out were fed, and then later on doing vaccinations and medications and other things. So yeah, thank you for pointing that out.
Yeah, Papakolea has done an amazing job. And I don't know if you noticed, one of those pictures was of a bunch of Christmas presents. They did a toy drive and made sure that every child that lived within the Papakolea Homestead community got a present for Christmas. And those kinds of acts, can really make a difference for families that are struggling. And I think they did such an amazing job of pivoting during COVID and put so much effort into making sure that their community was protected. They have been and will likely continue to be a leader within the homestead community that other homestead associations can partner with. And I know that Kapolei has tried to do the same thing. So I think really finding ways to support these community programs, also looking for ways that I saw somebody in the chat said, when we see Hawaiian patients, do we prescribe cultural activities? There are the homestead communities that are offering Ola Ho'i Kahula. Queens Healthcare Systems offers Ola Ho'i Kahula out of their ambulatory care setting. So there is the start of being able to prescribe these programs, but we haven't had enough of a shift in terms of the policies to be able to do that on a regular basis. I think you can talk to your patient about what they've done in the past, what they remember doing as a child, what they remember their families doing, because you don't want to assume that every Hawaiian is going to want to surf or do hula or paddle. But just talking about some of those things, getting to know them outside of their lab work and their medication list, I think is important when you're starting to think about putting together a holistic treatment plan. And, you know, something our department is doing and hopefully other people will advocate for is trying to talk to our insurance companies about covering cultural activities as part of our insurance coverage. So if you want to go join 24-hour fitness or you want to join Weight Watchers, your HMSA insurance will pay for it. But if you want to go to a halau for hula, or you want to you know, have access to poi and healthy fruits and vegetables, those things are not necessarily reimbursed by the healthcare system, but that could be something that we could look at. The reimbursement for activities assumes everybody wants to go to the gym, and maybe people don't want to do that. We have community-based healthy eating programs. The Pili Ohana program is one of those that, if that was reimbursed by insurance, it could be something that you could prescribe to your patients. So I think that's something that we need to continue to push the envelope on.
Thank you, Robin. I think you really kind of illustrate the 5 M's of geriatrics. You know, when you talk about asking the patient what matters to them, I think everything else should revolve around there. Finding out what their interests are, what their goals are in life. Good point. Aida put something in the chat. We will have a PDF of this presentation on our Grand Rounds website, which you can access. And there will also be a recording for people who may have joined late. You can watch it again on our website. Are there any other questions? We still have a few minutes. If people have any questions or comments, please just jump right in.
I'm not stopping the questions, but, you know, I really, my goal in today's presentation was, you know, goes back to that Bobby Ke Aloha patient. And I really want people to think about the things that we're telling our patients, the ideas that we share with them, because without meaning to, sometimes we say things that completely shut down their ability to be able to make a change in their healthcare. And I think it's easy for us to look at, well, so many of my Native Hawaiian patients have diabetes, therefore there must be this genetic predisposition. We really need to look underneath that, and we need to talk to the patients about what choices they are able to make and how we can support them in those choices. I had a patient who was hospitalized for diabetes, and she was put on a diabetic diet while she was in the hospital. They were able to get her off of insulin injections and just put her on oral medications, thinking that was what was best for her. But nobody talked to her about what choices she was going to be able to make once she was outside the hospital. And at that point, she was in a boarding house. The woman who ran the boarding house was the one making the food, which typically was some sort of meat and rice. She was not able to do a lot of activity because she had diabetic ulcers on her feet. She couldn't exercise much. And the injectable insulin was the way that she was controlling her sugars, because she couldn't make the healthy food choices they needed her to make in terms of what she was putting into her body. And the injectable insulin allowed her to be able to control her sugar. When they switched her to oral medications, they took away her ability to control her sugars. But that conversation was never had about what was going to happen once she left the hospital and the dietitians weren't preparing her meals. So that's the context we need to think about when we're working with patients and trying to figure out how to get them to be as healthy as possible.
Very good point. One of our fellows who's relatively new to Hawaii says, thank you for enlightening us, for those of us who are new to Hawaii. So yeah, that's a very good point. Any other thoughts or comments from anyone? Okay, if not, I just wanted to say thank you again to Dr. Miyamoto for a very wonderful presentation, putting things into context for us in terms of history as well as current day about what's been happening with the Native Hawaiian population. Thank you so much, Robin. We really appreciate you talking to us.
Thank you. Thank you, everyone, for your attention today.
Okay. Okay, bye, everyone. Don't forget to do your evaluations for CME.